Hello, everyone, dear colleagues. It's a great pleasure for all three of us to start this webinar, and we want to thank the UEG kindly for this opportunity to talk about the European guideline on IgG4-related digestive diseases, which is also a great thank you to the UEG task force of quality of care. The first question always when we are doing this stuff online and not as we did it before, where we really were seeing each other, is whether everybody can hear us speaking. And if there are any technical problems, please use the chat function and come back to us to let us know that there are difficulties. Before we start, I want to briefly introduce the two speakers. And we have really the best of the best today speaking. We have, on the one hand, Professor Vincent Rebrour from Paris, who is an absolute expert in all gastroenterological diseases, and especially in IgG4-related GI diseases. And on the other hand, he needs no introduction, also as Vincent, Professor Matthias Löhr from the Karolinska Institute in Stockholm, who's the father of this guideline together with Uli Boyers. So as you can see, we are in the best hands to ask all the questions that we might have on our minds regarding IgG4-related diseases. And we will have a good discussion, I guess, in the end. At this point, I want to motivate every one of you to ask their questions by the chat function. So if you have anything on your mind, questions that should be answered, then don't step back. Please ask your questions, and we try to get all the questions answered. If this is not possible due to the time limitation, then maybe we can do this by email in the end. Of course, as all of us have experienced in the latest weeks and months, sometimes these technical things don't work as we like them to work. So if this would happen, then please stay calm. We try the best to fix it as soon as possible and come back to you to conclude this really interesting and important topic during this UEG webinar. Finally, just for your notice, we will have the question and answer session after the two talks. We have some questions beforehand that we will ask you to answer. And then during the talks, the two speakers will come back to their questions and comment on your answers regarding the questions they have raised beforehand. Before we get started, it would be very useful for all of us to know who's listening. And as such, we have prepared one question, and I want to ask you to answer the following question, which is the first question. Could you please send the question in? Where we just want to see whether you are a gastroenterologist, a specialist in internal medicine, a general practitioner, surgeon, or have another specialization. And as we can see, this moves very rapidly, which is impressive in comparison to other platforms. And as you can see, most of the listeners are gastroenterologists, should be also specialists regarding the topics we are discussing here, even if this is quite a difficult and sometimes hard topic in the daily clinical life. Oh, we have one pediatric gastroenterologist. Very welcome here, I can see in the chat. So thanks a lot for all the feedback so far. It's great to have you all on board. And we would now start with the first presentation given by Professor Matthias Löhr from Karolinska Institute in Stockholm. As I said before, he is the head of the UEG guidelines, just published recently in the UEG journal. And before we start with the presentation, there will be 4 questions Matthias wants to ask you, and then we will see how you respond. And during the talk, he will refer to the answers and tell you what the right answers to the questions would be. So let's start with the first question from Matthias. This one you did perfectly. Now here's the next one. Okay, the question is IgG4 in serum sufficient to diagnose autoimmune pancreatitis? Easy one, yes or no to answer. And then later on, we will come back to this question and see whether all of you are right, the majority is right, no one is right, we will deliver the response very soon. So, okay, we note for ourselves to keep it in mind, most of you think it's not correct to use IgG4 serum, or it's not sufficient to diagnose autoimmune pancreatitis. Okay, next question. Autoimmune pancreatitis will resolve entirely, which is restitutio ad integrum, when treated. Yes or no? And again, this delivers very fastly. And we have, now a different picture than before. Roughly 2/3 say yes. No, there is no restitutio ad integrum, but at least 1/3 believes yes, this is possible. Okay, we move on to the next questions. So, if you want to diagnose IgG4-related disease in the digestive tract, this is done by, as we have mentioned before, serum IgG4, ERCP, cross-sectional imaging, rectal biopsy, breath test. Much more difficult at this instance, and you can see there's a variety of answers here. But the majority, nearly half, says serum IgG4 is a good marker and should be used. Maybe others are also correct. We will see later on whether you need more than one parameter to diagnose IgG4-related disease. Okay, then we have just one final question before the talk will start. The majority of patients with autoimmune pancreatitis will develop pancreatic exocrine insufficiency, diabetes mellitus, C, diabetes insipidus, or D, renal insufficiency. Again, maybe not the easiest question, but this is what we want. We want to challenge you. And Matthias will then elucidate in his talk what maybe the best answer is. Okay, so 61 or roughly 60% think pancreatic exocrine insufficiency, and then a few diabetes mellitus, and the others are not so often named. Okay, I think this was a very good start. We know who you are, you know who we are, and we have some thoughts on IgG4-related disease summed up here. And now Matthias will give his excellent presentation, and maybe things will change thereafter. So Matthias, the stage is yours.
Thank you very much, Jonas. It's a pleasure for me to do this together with more than 140 participants. Quite impressive. And I would like to take the diagnostic part on these IgG4 related guidelines under the auspices of UEG, which is in line with the way UEG works, primarily an activity of the national societies within the quality care committee. And in so doing, it is my Swedish Society of Gastroenterology and the Dutch Society of Gastroenterology who were doing this together with the European Pancreatic Club. My disclosures are these, and of course I have to thank UEG and the Quality of Care Task Force for supporting financially the making of the guidelines. It started actually out with these guidelines, and they will be part of what I'm talking about, which were actually the first UEG evidence-based guidelines issued by UEG on chronic pancreatitis. And after that, then, as you can see, there was a mentioning of autoimmune pancreatitis, which should be considered if the etiology is unclear. And then the next step then was that we developed these guidelines, which Jonas was already referring to, and he, like Vincent and many others, were part of it, and it was published earlier this year in our journal, UEG Journal. Now, just a few words outside the guidelines. What is the incidence and prevalence of autoimmune pancreatitis, for instance? It's about 6%. So is it a frequent disease? And as you can see here, the different studies give and take about 6% of patients with some kind of chronic pancreatitis eventually will be diagnosed as having autoimmune pancreatitis. Now, 6%, it's in between rare and not so rare, I think. It's a significant part. Now, talking a little bit more about not only the Autoimpancatis, but also the bile duct, the IgG4-related disease is a systematic disease, and this is really important to keep in mind. But the two organ systems which are mostly affected are indeed the pancreas, that is the Autoimpancatis then, and the bile ducts, which we would like you to call IgG4-related cholangitis. This was one of the things we came forward with during the making of the guidelines, that this should be the preferred term for this kind of disease. And it is, as I used to say, a pas de deux on the papilla, because this is exactly what it looks like for the pancreas, affection of the gland, here the sausage type, and then you see the contrast enhancement of the distal bile duct, also actually the kidney lesions here. And this is then the gross histology, the thickened pancreatic duct in almost normal appearing pancreas at this time here. And then upon histology, this so-called storiform fibrosis, and then these star-shaped appearance of the larger ducts, both in the pancreas, but it also appears to be the same in the distal bile duct once you have in cholangitis. Now, to the guidelines, and you will also see the grading down here, so you can basically immediately see whether this is a good or bad evidence. And this is already coming back to my first question: are serum biomarkers that can be measured to establish the diagnosis? And IgG4 in serum alone lacks sensitivity and specificity, but can be helpful and should be measured. Particularly, you can use it during the course of the disease. And this was then the second part of this question. Now, furthermore, is the measurement of carbonic anhydrase CA19-9 recommended to rule out malignancy? And as usual, this marker, it can be elevated for a variety of reasons, including chronic pancreatitis, cholangitis, and smoking. So therefore, it is not made to make the distinction between, say, a tumor or Autoimpancatis. But for most of the part, if there is a suspicion of tumor, of course, we are doing these kind of measurements. Now, what are the characteristics of IgG4 in the pancreas? It is then called type 1 Autoimpancatis, and this is the lymphoplasmic infiltration, the fibrosis, the phlebitis, and of course the increased number of IgG4 positive plasma cells, which you can see here in brown. And there is, of course, good evidence and accordingly a good recommendation attached to that, and a huge agreement in the group. What is the imaging features? The classic imaging feature, again, is the parenchymal enlargement. Here's another picture with this sausage-like appearance, which is pathognomonic. If you see that, the radiologist has no problem whatsoever to establish the diagnosis. However, these features may diffuse and focal and can be highly variable. Another feature are strictures in the main pancreatic duct without an upstream dilatation. This is another feature which you only see in autoimmune pancreatitis. What is the role of endoscopy to diagnose autoimmune? Well, it can be suggestive, but we also use it to take biopsies. And biopsies should be taken not with a fine needle aspiration, but with a true cut biopsy, because then the yield is much higher and you have a chance even to do some IgG4 staining on these tissue pieces. So therefore, if you do EOS, then please do the biopsy with a real needle and not just an aspiration cytology. Now again to the pancreas. Autoimpancatis is a special and treatable disease or form of chronic pancreatitis. There are long-term sequelae, which is the exocrine and endocrine insufficiency, coming back to my last question. Therefore, screening for deficiencies, that is malnutrition parameters, that is vitamins, for instance, trace elements, should be done in line with the other guideline on chronic pancreatitis from Harper-Neu. Because of this, and some chance, quote unquote, to develop a tumor, the lifelong follow-up of patients with Autoimpancatis is advisable. As you can see here, now to these sequelae, and I'm coming here to our own study in more than 70 patients at that time, and here the sequelae was that in type 1, 2/3 of the patient have exocrine pancreatic insufficiency, and even more so, there were also a good third who had diabetes. What is even more intriguing is in Autoimpancatis, both the atrophy of the gland as well as diabetes develops double as fast as it does in ordinary chronic pancreatitis. That is to say, yes, there are these sequelae, and no, there is no restitutio ad integrum in those patients. Now we are coming to the bile duct. And as I also already told you before, the most common manifestation of IgG4-related hepatobiliary diseases is what we would like you to call IgG4-related cholangitis, IRC. There have been other terms which are basically also told in the guidelines, but we would like this not to mix up with other forms of cholangitis. There is a very interesting feature which is coming from the Dutch group, that particularly the cholangitis as part of the IgG4-related GI diseases in conjunction with the Autoimpancatis is related to blue-collar work. And we have very recent evidence from our own patients that this indeed is the case, and I'm very happy that I could confirm this finding of Ulrich Beuers, because I very much like this idea that we have some association which he can also underline with findings in the immune surveillance of these patients to this kind of professions. 30% in our cases. Again, you see the thickening of the distal bile duct here, the fibrosis, this kind of IgG4 positive cells, which is making up the cholangitis, which is basically similar to what you see in the pancreas. Also, similar to the Mayoya classification for PSC, there is a proposal for a classification of the changes in the bile duct intrahepatically, but also in the distal bile duct, which we also propose and use and even show in our guidelines, making reference to the original description of Nakazawa. So if you see these patients, please use this classification so that we can later on come back and teach us something about these forms of IgG4-related diseases. The clinical, biochemical, pathological, and radiological characteristics are as follows. Jaundice can be an initial feature. It can also be just the occlusion of the distal bile duct by the autoimmune pancreatitis, but it can also be the stenosis in the distal bile duct, for instance, or further up in the hilus. IgG4 can be elevated both in the serum and in biopsies taken, for instance, during spyglass, as you can see here, which we do regularly if there is some kind of suspicion of a malignant stenosis, for instance. So there are good features to identify and diagnose the IRC in patients with IgG4-related GI tract diseases. We also looked into other subclasses, and indeed, you can use the IgG2 subclass to make the distinction between PSC and IRC, which is, I think, a very important feature, because sometimes, at least from the beginning, it is not clear from the presentation of those patients. I already referred to this. What is the risk of cancer development in the context of IgG4-related diseases, particularly for the pancreas? There is an association, but at present time, we cannot tell which is the hen and which is the egg. That is to say, whether IgG4-related diseases, such as in this case autoimmune pancreatitis, is comparable to ulcerative colitis, paving the road to further development of a cancer. So that is still open. Now, I'm coming now to the other guidelines here, which from the rheumatologist, and they talk about how to do the diagnosis. But furthermore, they are also referring to how to establish the diagnosis, and they, for instance, also make the distinction that a biopsy should be taken 94%, even if the evidence is rather low, but it should also be seen in conjunction of clinical symptoms. And is the summary for the diagnostic workup, which is in line actually with the guidelines for both the Autoimpancatis and the IgG4-associated cholangitis, as it is still here called. If you have the suspicion, the typical imaging is something which is central here, and together with, say, the IgG4 and other organ involvement and biopsy, you could be establishing the definite diagnosis, which then would trigger the treatment, which you will hear about in a minute. The same holds true for the biliary part, where you could look at, for instance, tissue pictures and then do the imaging and the IgG4 in the serum, and then come to a definite diagnosis. And again, part of our guidelines, which we took over from the Japanese, you could always then give it a short treatment, and Vincent will talk more about that, how this is going to be done. But this is also part of the diagnostic workup to try steroids in some of these patients. I stole this picture from Michel Fernandez, who talked during the last webinar on how to approach these patients diagnostically. And I like this picture a lot with the cheesecake. Do many things. Eventually, some of this will stick, and try and give you the chance to establish the diagnosis. This is the Swiss cheese to diagnose IgG4-related diseases. I would like to thank primarily Ulrich Boyers and Miroslav, who are leading me to establish these guidelines. All the others, including the chairman here and my co-speaker, who were pivotal in developing those guidelines, and then also the UEG Guideline Working Group, who were essential in making the guidelines as good as they are right now. Thank you very much. The last reference will be done at the end as to the app. And this is Stockholm today at Nobel's Day, but there is no kind of party, no handing out of Nobel Prizes. It's a very sad day for Stockholm today. Thank you very much.
Matthias, thanks a lot. This was a perfect talk about the diagnostics of autoimmune diseases, autoimmune pancreatitis in special, which is not easy to make. And referring to the questions we have asked at the beginning of the webinar, it seems that we have an expert panel as audience, which will make the discussion even more vividly. And I hope all of you use the chat function to ask the next time. Before we now move on to Vinciane, Vinciane also has raised some questions she wants to ask you before she starts with her talk. And we now have to, unfortunately, take away this nice picture of the summer cottage of Matthias, which is beautiful, as you can see, and ask the questions. And we start with the first question, which is, if you have patients with confirmed IgG4 disease, would you propose a treatment for patients with no symptoms, but with an elevated IgG4 serum level? And we're looking forward to your answers. You have just yes or no. And it seems that you are 50-50 in the end. So we have now around 150 participants in the audience and voted roughly 100, but it will stay in the end that it's 50-50. So let's see what we will learn during the talk of Vinciane regarding this point. We have another question for you, which might also be very interesting to see how you answer. After treatment of an IgG4 flare by steroids, would you propose a maintenance therapy by low-dose steroids to limit the risk of relapse? I guess every one of you who has patients in his outpatient clinic or on the ward has asked themselves this question very often, and it's difficult to answer with evidence. Maybe we will learn this later on, but maybe it's quite easy. Vinciane will show us. So again, we have yes maintenance, roughly 44%, and no 56%. Okay, interesting answers. So one final question before we move on to the next talk. And this question is, in case of patients with IgG4 disease complicated by cholangitis and jaundice, do you recommend biliary stenting in association with a steroid therapy? And of course, all endoscopists like stenting and like doing ERCPs, but is it really necessary to do this? And you can vote again, yes or no. And then I'm sure here we will get a very clear answer what to do in these patients, as we have Vinciane who will give the talk very soon. So we will keep the answers in mind, you also, and then let's see what happens during the talk. And I hand over to Vinciane, an absolute expert in the field. Maybe she has not the same summer or the same nice summer cottage as Matthias, but
she has another one nice. I hope.
Yes, I guess yes. Vinciane, the stage is yours.
So, thank you very much for this very, very nice introduction, Jonas. I'm very happy to be with you tonight and to propose this talk about the treatment of IgG4 disease. So I will try to...
I guess we need to...
Okay.
Now it's better.
Okay, thank you.
Slide.
So thank you very much, Jonas and Matthias, and I really thank you, the UEG, for its support for these guidelines and for all they made for us and for gastroenterology in general. So here are my disclosure of interest. And I will talk about specifically about the treatment. So first, just before to talk about treatment, I just want to remember you that IgG4 disease is a systemic disease, as you know, and as Matthias showed you just previously. And the digestive disease in the IgG4 disease are a main part of all the organs who can be involved by the disease. So you won't see me, but it's not a problem. So
it's a pity, honestly.
It's okay. So I'm very sorry for those who can't listen to me previously. So I was talking about the recommendation which was published by an international consensus 5 years ago, and they propose urgent treatment in case of risk of organ insufficiency. And the first one was proximal biliary strictures, just to limit the risk of fibrosis and cirrhosis. But the second one was pancreatic enlargement, and they proposed a treatment just to limit the risk of pancreatic, exocrine, and endocrine failure and insufficiencies. So this last point could be largely debated, and notably the treatment to limit the pancreatic exocrine insufficiency, and can be debated. That's what we did with a group. And when we propose another statement, is that for now in the literature there is no relevant data to support that a treatment should be proposed in patients with pancreatitis without symptoms, just to limit the risk of exocrine and endocrine insufficiencies. So it can be debated, but for now it's not a recommendation if your patient has no symptom, I mean no pancreatic pain. So the treatment that we recommend first line was a glucocorticoid steroid at a dose around 0.6 to 0.8 milligram per kilo body weight daily, orally. And typically we can start with a dose between 30 to 40 milligram per day, prednisone equivalent, for 1 month to induce the remission. So I just want to notice that in case of people with obesity or overweight, we can propose a higher dosage of prednisone. So this response to this initial treatment have to be assessed at week 2 to week 4 with a clinical, biochemical, and morphological markers. So steroid therapy, then after 4 weeks of treatment, full treatment should be gradually tapered by 5 milligrams every 2 weeks. So I want to now explain what we propose this statement. So steroids as the first line treatment. The publication that I want to highlight is this one published 7 years ago, and in this large cohort, which was a multi-center international studies with from 10 different countries. They included more 1,000 patients with mainly type 1 pancreatitis, I mean IgG4 disease. And we can see that in this situation, steroid therapy could we could have some successful remission in more than 99%. And this is a large cohort, but there is a few other, numerous other studies which publish exactly the same results. So that's why steroids are the first line treatment. So I want to show you now this very small study, but it's a well illustration of the evolution after steroid treatment. So here is the biological evolution of the enzyme of the liver, and we can see that just after 2 weeks of treatment, and then after 4 weeks of the treatment, there is a normalization of all the pancreatic enzyme. That means that just after 2 weeks of treatment, these biological abnormalities will get normal. So it's exactly the same for the radiological response. And I think about a mass when there is a pseudotumoral mass. After glucocorticoid therapy, just after 2 weeks of treatment, you can see a very good response in more than 80% of the patients. And after 3 weeks of treatment, we get 100% of good response, I mean for biliary tree and pancreatic abnormalities. So in case of jaundice, should we propose biliary stenting? It was one of my questions, yes or no. And I think that we can say no, we did not recommend to associate biliary stenting if you begin a steroid therapy, because we have seen that in 2 weeks, in majority, the liver enzyme will get normal. So if there is no sepsis, of course, there is no indication for biliary stenting. You have, of course, to clearly tell your patient that in case of fever, you have to come back very urgently during the first days at the hospital. So here it's an illustration. You can see just before the treatment, and after 3 weeks of treatment, we have seen that a quite normality of the cholangitis here on this MRI. So we have to think, of course, not to limit this treatment to steroid. You have to associate it other treatment, and it's very important, as Matthias said previously. You have to associate it analgesic if needed, pancreatic enzyme if there is pancreatic exocrine insufficiency, and of course to treat diabetes. Be aware of diabetes because it's a very strange disease. Pancreatic autoimmune pancreatitis, because diabetes could be resolved just after steroids. That's a paradox of this kind of diabetes, but sometimes it could be exactly the same. So you have to tell your patient to be very careful regarding the treatment of diabetes. So in case of doubt of cancer, because it's mainly the problem sometimes in case of pseudotumoral form, so should we propose a therapeutic test with steroid? So the rationale of this test is that, as I already told you, that more than 90% of the patient will do response, to steroid. But we have to know, and I know that you already know this notion, that even if you have a cancer, if you take some steroid, you will feel better the first days. So you have in practice to perform a complete, clinical, biological, and morphological workup very quickly, probably week 3 or week 4, just to be sure that the mass that you suspect disappeared quite completely and you can rule out a cancer. So here it was one of my patients. You can see here on this MRI with there is a mass here, and the main pancreatic duct completely disappeared. That was, of course, we can think about a cancer, but there is no upstream of the main pancreatic duct here, no dilatation. And after 4 weeks of treatment, you can see a very small atrophic pancreas with clearly sign of chronic pancreatitis. You can see here on the MRI. It was exactly the same. He gets a huge cholangitis, and after treatment, we can see that quite everything was quite normal for the biliary tree. So what is the risk of relapse? We have seen in the same study published 7 years ago that after a first treatment by steroids, the risk of relapse was in this cohort of pancreatic autoimmune pancreatitis type 1 around 35%. So it means that probably more than 1/3 of the patient will relapse. So is it an indication for maintenance treatment? That was one of my questions, and I really enjoy that for all my questions, all the result was 40%, 40%. So it means that it's really a problem to get the right treatment for this kind of disease. So there is no clear consensus if we have to propose some low-dose steroids therapy or immunosuppressant. So first, I want to show you this randomized control trial, which was published by a Japanese team. So they included patients, and they proposed maintenance therapy by steroids during 3 years after a first treatment for the flare by steroid. So this group gets therapy with 5 milligrams steroid per day, and the other group, the cessation group, did receive anything. So what is the result? We can see that the rate of relapse during these 3 years was around 78% for the group of the cessation group and 23% in the maintenance therapy group. It means that, of course, there is a difference and there is less relapse in the maintenance therapy group, but there is still relapse. That's why it's not so clear if we have to propose it maintenance therapy after a first treatment. So what we propose when we have to write the statement is that adding immunosuppressive agent should be considered in case of disease relapse as maintenance of remission strategy and in patients with a high risk of disease relapse, particularly in the case of multi-organ involvement. So the second statement was that if there is no change in disease activity or the disease relapse during the 3 months of treatment, then an immunosuppressive drug should be added. So the other question, the other issue was which immunosuppressant for which patient should be proposed as treatment for this IgG4-related disease. And what about the secondary effect of the systemic treatment? So the first statement is that probably the treatment that we have to propose second line after the first line with steroid is rituximab. So rituximab is antibody 20, and if patients are resistant or intolerant to high-dose glucocorticoid to maintain remission or have failed to respond to immunosuppressive therapy, so we have to propose this therapy. There is two different protocols we can use. The first one was the first proposed by the Mayo Clinic. The dosing protocol is 375 milligram per meter square body surface weekly for 4 weeks, followed by infusion every 2 to 3 weeks. The second protocol, that's what I do personally, is 1 gram infusion 15 days apart every 6 months. So the immunosuppressant use, the other one, could include teoperin, azathioprine, and 6-mercaptopurine, mycophenolate, mofetil, methotrexate, or calcineurin inhibitors. So why would you propose rituximab? The first experience was published by the Mayo Clinic 7 years ago, and they propose immunomodulator and rituximab for patients we had relapse after this treatment. So what we can see is that patients we were treated by azathioprine, they had a disease remission in only 23%, and they get relapse on treatment for 30%. It was quite the same for the two other drugs, I mean the 6-mercaptopurine or with mycophenolate mofetil. So, and when we look to the different risk factors to have some relapse, it was, of course, the involvement of other organs. So they use and they propose rituximab, and they repeat infusion every 2 or 3 months during 24 months. It could be debated, and I think we have to debate these repeated infusions. But during the follow-up of the maintenance phase, they did not observe disease relapse. And at the end, more than 80% have complete remission with no relapse during this maintenance therapy. So the other studies I want to show you is this prospective trial. They included 30 patients with 2 doses of rituximab, and the patient was treated with rituximab alone or associated with baseline glucose steroid therapy. Many of these patients had previously received steroid-sparing agent as azathioprine, methotrexate, or rituximab, but of course no participant had rituximab within 6 months before the inclusion. And when we look to the result, we can see that the disease response at 6 months was more than 97%, and we observe complete remission at any time of this trial for 60% of the patient. So the duration, the time to the disease response was very, very quick. It was the mean was 40 days, and the time to relapse was only 210 days. It means that probably we can propose some rituximab infusion just in case of relapse, but we could talk and debate about that. So the second point is that the retreatment with new rituximab infusion during the first 12 months was only for 13% of the patient. So the third and last study I want to show you is also this cohort of patients treated with rituximab, and it was 33 patients with mainly numerous and several organs which was involved by IgG4 disease. And we can see they propose mainly the protocol with 1 gram, which 2 infusions, 2 weeks apart. and we see that the relapse was, the median time to relapse was quite 20 months, and they have to retreat patient only for relapse only in 27% of the patients. So when we look, the risk of disease relapse following rituximab for patients with or without glucocorticoid maintenance was exactly the same. When we look to patients who receive rituximab with or without rituximab maintenance, of course, if there is no rituximab maintenance, there is more relapse, but we can see that the median time to relapse was more than 20 months. So, and just to finish, I want to highlight the use of Teoperin. Before we use rituximab, we use, of course, to use azathioprins and Teoperin in general. So I think that now we have to be careful, and personally, I don't use Teoperin anymore for my patient, and I want to remember this great cohort with quite 20,000 patients we were included with inflammatory bowel disease, and you know that azathioprine is mainly proposed for this kind of patient, and we know that after a lot of years with this kind of treatment, there is a risk of lymphoproliferative disorder between patients who receive Teoperin during for this disease, and the odds ratio was more than 5, and the risk of lymphoproliferative disorders was mainly for males, and males more than 50 years old, which is the population of patients we could observe with IgG4 disease. So let's be careful with the use of azathioprine in particular. So I really want to thank you once again, Jonas and Matthias, and of course the UEG and the opportunity to present these results, and the opportunity, of course, to propose these guidelines to all. So thank you, and please let me apologize for the technical problem once again.
But let us see you again now.
Dear Vincent, thanks you very much. This was an excellent presentation, and we can see that this topic in regard of diagnostics, in regard of treatment, is really difficult, and we need the experts like you and Matthias to guide us in this regard. We will refer to the UEG guideline app that you saw briefly in the presentation at the end of this webinar again. So now we come to the questions that have been raised by several of you as the participants, and we want to thank you once again for your patience during this technical issues that we had, and apologize for this. And we want to start with a question regarding diagnostics. This question was raised by 2 of the participants, and it is about the quality or the diagnostic yield of biopsies of the papilla to diagnose autoimmune pancreatitis.
Yeah, maybe I should take that question. In one of my questions, there was the rectal biopsy mentioned, which some few percent thought would be diagnostic. Now, we don't do that. There was a proposal by the Italians who propagated this several years ago. Instead, what we do, if we have some kind of reason to do some kind of endoscopy, indeed, we take a biopsy from the side of the papilla. Now, this is not in the hands of unexperienced endoscopists. This can be causing acute pancreatitis. So one has to be really careful with this kind of biopsies. But if you could show, say, IgG4 positive cells in the tissue from the papilla, then of course you could establish the diagnosis. The reason being why this is propagated and recommended, and even for that matter mentioned in the guidelines, is that you have a certain proportion of patients where the IgG4 in serum is normal, albeit it's positive, that is high in the tissue. And this proportion is ranging between 10 and maybe 20%. So there is a good rationale to get some kind of biopsy, if not the imaging, as I showed to you on my CAT scan, is so convincing that even in the absence of IgG4 elevated in the serum, you can establish the diagnosis and treat the patient.
So you would not use it in first instance?
I wouldn't. I would only use it in patients where the serum is normal and where maybe the image from cross-sectional imaging is not conclusive. No. But then again, we would normally at our institution then opt for endoscopic ultrasound, and as I said, take then a real good biopsy rather than an aspiration cytology.
Okay. There's one question for you, Vinciane, and it is,
yes.
What do we do if the patient has fever and elevated CRP, and we expect that he has a cholangitis? Should we perform ERCP and stand in these patients?
So yes, I think if there is fever and if you think that there is sepsis, I think that we have to. The problem is that there is not only cholangitis of the main biliary duct, but sometimes cholangitis in all the liver. And the problem is that if you do some ERCP, I think that you will trap some the sepsis in the biliary duct if there is a diffuse cholangitis in the liver. So, of course, you have to hospitalize your patient. You have to propose stenting with antibiotics. And but it's very, very rare. I think that, as I told you, steroids are very, very efficacious. So we never. So I never had this problem with the patient. So
I agree.
So antibiotics first, if the patient is stable enough, no ERCP, and then start prednisone treatment.
Absolutely. So if you have some trouble with this kind of patient, you are not sure that it will be all right, you can keep your patient for a few days to be sure that he gets steroids, and that the answer is very, very quick with steroids. So if you have some trouble with your patient, you are not sure, you can keep your patient for a few days in hospitalization if really you're really afraid about that. But usually it gets very well.
Okay. One other question for Matthias regarding diagnostics. In the instance you don't have endoscopic ultrasound and cannot biopsy by endoscopic ultrasound, would you perform CT scan biopsies?
Yeah, well, that's a very good question. We do not do transcutaneous CT-guided biopsies for this indication. And you rarely do this if you are not having, say, metastatic pancreatic cancer. So for such a quote-unquote benign situation, we haven't really done that. Again, if you can't do endoscopic ultrasound, I think the papillary biopsy is a good alternative. Mind you, it should be done by somebody who knows about the papilla and ERCP, so that you do it from the side, so to speak, not to cause any kind of edema in the papilla and then subsequent acute pancreatitis.
Yeah. Again, shows these patients should be treated in centers with expertise. This is quite for sure.
I mean, we try, of course, with this seminar, for instance, also to spread the knowledge. But what is very popular in Sweden, actually, we don't have to see all of the patients ourselves. We make quite a lot of use of telemedicine and communication with our colleagues, even sharing images, say, of CAT scan or MRI or even ERCP for that matter. So, I mean, there are measures to get an expert opinion and not having to, send the patient away, which I think is a good option.
Yeah, perfect. I think this is something we all should use in the future, as you do in Sweden, because this is the way forward, and there we should go to. There's another question for you, Vincian, regarding the treatment. If you have a relapse, would you use again steroids or change the drug?
Yes, it's a very good question. So, as you have seen, there is a great risk of relapse. But we just don't know if there will be a relapse 3 weeks or 3 months or 3 years after the first flare. So we have to be pragmatic. If you treat your patient one time and the relapse gets 3 years after, you can propose once again a steroid therapy. But if there is a relapse during the year just after the first flare, I think that you could already propose some immunomodulator, and I mean Rituximab. So it clearly depends of when you will observe this relapse. Just if it happens during the year, just after the first, or just after you finish the steroid therapy, you can propose some Rituximab.
Yeah. And would you change, if you take prednisolone again, would you change the doses, or would you start again with the same doses?
Exactly the same doses. What is very important, I think, is to taper very slowly and for a good impregnation of prednisone. So we mean that when you taper very rapidly, we can see very frequent early relapse. So you can't use 3, 4, 6 months just to stop the steroid, and you will probably limit the relapse, even it was not clearly demonstrated in studies, but it could help. But we can begin with the same dose, but be careful with people overweight or with obesity. You can propose sometimes 1 milligram kilo if you don't observe the response that you could expect. So.
Perfect. Very important points, and I think all of us can need these points for the treatment of the patients we see. One final question. We have some additional minutes due to the technical problems we had. To Matthias, to make this point clear, there's the question: if IgG4 is negative, then it's no IgG4-related disease. Is this true?
If IgG4 is negative in the serum, no, it's not true, because as I told you, you can have particularly autoimmune pancreatitis without having elevated IgG4 serum levels. Now, you could also have the type 2 autoimmune pancreatitis, and then obviously the IgG4 would also be normal. I mean, the IgG4-related disease as a systematic disease obviously is defined by elevated IgG4 serum, but even the rheumatologists have encountered manifestations of IgG4-related disease, say in the lacrimal glands, in the orbiter, or on very other quite exotic locations where you do not have elevated IgG4 in the serum. For instance, retroperitoneal fibrosis or more is one of those manifestations which we today consider being part of IgG4, and you can rarely see in these cases, for patients, for instance, elevated IgG4 in the serum. So as my question and what I showed in the guidelines told you, you cannot use this to establish the diagnosis. If it's positive, you have confirmation, but if not, and the suspicion is there, you must, for instance, obtain some kind of histological proof.
Yeah. So 2 very short final questions. First one to Vincian. There is a mass in the pancreas, and you try a therapeutic approach. How long will you treat the patient before you make the next imaging, just to exclude pancreatic cancer as the underlying cause of this mass?
I think we have to be very quick, very fast, and you have to repeat cross-imaging, sectional cross-imaging at week 3, week 4. You don't have to wait 2 or 3 months. If there is still the mass, it's a cancer. So you have to repeat biopsy and repeat again if you think that it is a cancer. So, for example, for one of my patients, I have to perform 3 times the biopsy because I was sure it was a cancer. And So
perfect. Very important point and very well taken. Matthias, last question to you. The risk of performing FNB in the pancreas. Did you see any complications?
Yes, I mean, again, I haven't talked about this, but obviously there is a risk of, causing acute pancreatitis, and we have seen that actually. I must admit, not so much if you do, say, a single biopsy, and for that matter, the aspiration cytology, where you basically hammer the needle in many times and aspirate during this procedure. This is more dangerous to the gland than taking, say, a single biopsy in a defined area. But still, yes, endoscopic ultrasound, taking biopsies is an invasive procedure and can cause, for instance, not only bleeding, but particularly acute pancreatitis. And I must admit, during the last, say, 10 years or so, we had maybe 1 or 2 cases where the acute pancreatitis was so severe in cancer cases, I must say, that the patients could not be operated in the next weeks or even month. So again, this is a technique for an experienced endoscopist and endoscopic ultrasound colleague.
Well done, perfectly. Thanks a lot to both of you for this excellent talks and for these excellent answers to the question. I think the feedback given here in the chat is perfect, and all want to thank you. Especially, we all want to thank you as participants for taking your time to visit this webinar. And of course, if you need further information, the UEG webpage has all the information you need in gastroenterology, so you can find all the documents listed there. There is the quality of care website where you can find much more information on the new guideline app that has been developed by the Quality of Care Task Force, which is excellently led by Wafa Kanusi, and I just can appreciate all her work she has done in this Quality of Care Task Force. And of course, we want to highlight that there will be a new webinar in the new year, maybe without technical problems, but we will see, which will be in March on microscopic colitis. And finally, of course, we want to thank the whole UEG team for all the efforts they have undertaken, for all the support. It's really great to work with you, and hope that you all have a perfect Christmas, the best as possible, and a happy new year. And hopefully we can meet in real life in the new year again.
And stay healthy and safe.
Yes,
Bye
absolutely.
Thank you, everybody.
Okay.
And thank
Thanks
you,
a lot
for a nice moderation.
Thanks a lot.
Thank you. Thank you.
Bye.
Bye-bye.